Good evening, everybody. From Yashoda Hospitals, every fortnight we bring an interesting discussion. It can be a case presentation or a presentation. So this week we are coming with the journal club. So there are two topics we have selected from two units of Yashoda Hospital. One is from Yashoda Hospital, Somajaguda. Dr. Swarna, third year resident, will be talking about the latest guidelines of sepsis. And the second speaker will be Dr. Karthika Pillai, second year resident. She will be talking about the head injury. So coming to these topics, the first topic is head injury. So which accounts for almost 69 millions of cases yearly. Of this, TBI is the leading cause of death. And out of all these, 30 to 40% cases, there is a mortality, 30 to 40%. And if you take the Indian statistics, which accounts for 1.5 to 2 million cases per year, and there's a trauma of almost 1 million death, which is mostly the head injuries. So RTA accounts for almost 60 to 70%, and which accounts for 20 to 40%. So India, which is leading the highest TBI globally. And the second one is sepsis. Globally, we see 49 million cases, 11 million cases deaths per year, and which accounts for 20% globally death. And World Sepsis Day we celebrate on September 13th, and World Trauma Day we celebrate on October 17th. So the first speaker, Dr. Swarna, she will go ahead. Dr. Swarna?
Yes, sir.
Yeah, you
good
can go
evening,
ahead.
sir. Am I audible, sir?
Yes.
Yeah. Is my PPT visible on screen, sir?
No.
Now is it visible, sir?
No. You have to share it.
One minute, sir. Sorry for the delay.
Karthika?
Yes, sir.
Is your PPT ready to share then?
Yes, sir. I can share, sir.
Yeah. Then you
Sir,
can
I'll
go.
start.
Yes.
Okay. Is it visible, sir?
Yes. So she has already started, then just be on the line.
So should I start this, sir?
Yeah, go ahead then.
Yeah. Good evening, everyone. Myself, I'm Dr. Swarna, resident emergency medicine in Yashoda Somajiguda. So today, let's see about sepsis and their updates. So first thing, we'll go regarding what is sepsis. So its definition and all. So sepsis is like in the first era, like it's like 2 out of 6 criteria plus suspected infection. It's called sepsis. So then, what is severe sepsis? So sepsis plus sepsis-induced organ dysfunction. It's called severe sepsis. Then in septic shock, lactate greater than 4 plus systolic BP less than 90 and which is not responsive to fluids or not able to maintain the MAP below 70. It's called septic shock. And then from 2001, it has been updated to like 2 out of 6 criteria plus suspected infection. And then with severe sepsis, like sepsis plus organ dysfunction, hypoperfusion, or hypotension. Then in septic shock, sepsis-induced hypotension persisting after adequate IV fluid resuscitation plus presence of perfusion abnormalities or organ dysfunction. Then coming to Sepsis-3, that is from the 2016, so where it is the criteria comes to SOFA criteria, where it is SOFA score greater than or equal to 2 plus suspected infection, where severe sepsis is not applicable. And then coming to septic shock, where the patient is requiring vasopressors despite giving fluids and not able to maintain MAP greater than or equal to 65 mmHg and lactates are elevated, then it's called septic shock. So then let's see what is the SIS criteria, which is like systemic inflammatory response syndrome. So where the temperature is greater than like 36 degrees 38 degrees centigrade, and then heart rate above 192 more than 100, and then patient is tachypnic, where his or her respiratory rate is greater than 20 and not able to maintain PO2 or PCO2. And then TLCs not ranging from 4,000 to 12,000. Then this is the main SIRS criteria. So SIRS criteria with infection is called sepsis. And then from sepsis with end organ damage, it's called severe sepsis. And then severe sepsis with hypotension is leading to septic shock. So what are the main screening tools? So the main screening tools we usually used to use are like SIRS, SOFA. What is SOFA? SOFA is sequential organ failure assessment score, and then Q SOFA, quick SOFA score, and then new early warning sign score, and then MU scores. So in all these things, so comparison screening tools for sepsis, then the more sensitivity, more specificity, where we can see is in SIRS criteria, it's more sensitive. But in later versions, in later on, the news and mu score nowadays are more sensitive and specific. So then coming to the like SOFA scoring, so the main credentials or the main targets what we see is usually the thing is on respiratory ratios like PO2 or FiO2 or SpO2 or FiO2, and then maintaining the MAP or not, like maintaining the BP or not. Then for coming to the organ damage, like we can see the renal values like creatinine, is the person able to maintain creatinine or not? And then the liver values, the total bilirubin, is the person is able to maintain the bilirubin or not? Then coagulation profile, where if the patient is landed up into DIC or not, where the platelets, is he able to maintain or not? And altered mental status, to see his GCS and all. So out of scoring this SOFA score from 0 to 6, if we are able to see, then it's like patient is at mild risk of mortality. From 6 to 9, it's moderate. If the score is greater than 9, then the person is at high risk of mortality. So then etiology, and coming to etiology and pathophysiology. So usually what happens in sepsis is, so when the person is attacked with some sort of infection, so there is something called immune activation. So when the immunity activates, like it releases some pathogens like PAMs and DAMs, which in result like gives a huge cytokine storm, where the patient resulting in fever and all. And then it gives the systemic inflammatory responses, where it causes vasodilatation, which reduces the systemic vascular resistance. And then it causes hypotension, where the patient will not be able to maintain the BP. So then there will be increased vascular permeability, then plasma leakage, then tissue edema causing hypoperfusion. So from there, it causes the endothelial injury. So cytokine release causes endothelial injury, causes leakage of plasma into the interstitial spaces, results of third spacing. So hypovolemia causing tissue hypoperfusion. So in this tissue hypoperfusion, where the patient's lactates will also get elevated. So where, and upon that, in the coagulation cascade, so these cytokines stimulate tissue factor expression, activates the coagulation pathways. So where the suppression of natural anticoagulants, so like suppression of the natural anticoagulants like protein C, antithrombin and all. So where it happens like impaired fibrinolysis causing microthrombi formation, and then tissue ischemia. So then progressing into DIC, disseminated intravascular coagulation and all. So then this causes cellular and mitochondrial dysfunction, though. So the mitochondrial dysfunction at the cellular level is seen. So it causes decreased ATP production and all. And then these leads to metabolic acidosis, cellular apoptosis, and then the organ dysfunction and all. So associated with that, in the adrenal glands also, the adrenal insufficiency starts, which the inflammatory mediators can suppress the HPA axis, which is like hypothalamus pituitary adrenal axis, which can result in inadequate production of cortisol and vasopressor. So, which is not able to, the patient body will not be able to maintain the BP. So here in these situations, in the newer guidelines, where the patient can be supplemented with additional steroids like hydrocort and all. In later on slides, we'll discuss regarding that. So now, when coming to the ED evaluation, so first comes when the patient, as arrival to ED, as we know, like we'll start with the history taking, then physical examination, then our regular ABCD approach, then treat the clinical findings like hypoxia, respiratory distress, hypoglycemia, hypotension, temperature. And then coming to the systemic examinations, patients should be assessed for the tissue hypoperfusion, like altered mental status, capillary refill time, skin, urine outputs, lactate levels, and then check for POCUS, mainly our IVC to guide for the fluids and all. Then the lab investigations need to be done. Then we can, like, so that we can see the platelet level, TLC levels, creatinine, our total bilirubin, like you can send CBP, RFT, LFT, coagulation profile like PTINR, APTT, then lactate levels and procalcitonins, then imaging if necessary. So if you are suspecting the source is like any abdominal or renal issues, to see any pyelonephritis, and also those kind of imagings are necessary. So then coming to the lactates, so in sepsis and septic shock, lactate levels or lactates play the major role. So here the elevated lactates is thought to be due to tissue hypoxia and hypoperfusion in the patients with shock. So other causes of elevated lactate in shock patients include beta-adrenergic stimulation or hepatic dysfunction and lactate generation by the lungs. So new literature suggests that 24-hour lactate clearance predicts 90-day mortality better than initial lactate clearance rate, because initial lactate clearance is heavily impacted by underlying medical comorbidities. So here the Andromeda shock trial compared resuscitation guided by lactate clearance. So it decreases of 20% in every 2 hours. That means if the lactates are elevated, the patient's lactate level should be measured every 2 hours to see how the lactate clearance is going on. So here, if the lactates, if in the repeat testing for lactates, if the lactates are elevated, so we need to see we are missing any source of infection to treat the sepsis. So with that resuscitation, we can further go with the lactate clearance. So here, the Andromeda shock trail compared resuscitation guided by lactate clearance with resuscitation guided by capillary refill normalization, and found significant improvement in SOFA scores at 72 hours. So in clinical practice, if initial lactate is greater than 2, we suggest obtaining a repeat level to ensure improvement after resuscitation. If repeat lactate is not improving, consider whether there may be additional identified pathology contributing to the aberrant metabolism. So these are the potential sources of sepsis, where we can see for the infection is like from coming to the gastrointestinal. So you can see if a patient is having some infectious hepatitis, cholecystitis, appendicitis, perforated viscous, cholangitis, diverticulitis, abscess, pancreatitis, infectious colitis, spontaneous bacterial peritonitis. Coming to the genitourinary, pyelonephritis, abscess, renal calculi, urinary tract obstruction, or acute prostatitis. Coming to the pelvic diseases, you can see peritonitis, abscess, septic abortions, endometritis. Then coming to the lower respiratory tract, pneumonia, emphysema, septic emboli. Intravascular, you can see CRBSS like catheter-related bloodstream infections, either from central line or permacaths or HD sheets, or prosthetic device infections. Coming to the cardiovascular, you can see endocarditis or myocarditis. Coming to the dermatological infections, you can see with abscess or toxic shock syndromes, and then Stevens-Johnson syndrome or cellulitis or necrotizing soft tissues infections. And then coming to the neurological, you can see with meningitis, epidural or intracranial abscess or discitis. Coming to the musculoskeletal, osteomyelitis, septic arthritis, infected hardware, or necrotizing soft tissue infections. Coming to the treatment, so in the first 3 hours, suspected sepsis, so you need to measure the serum lactate, obtain the 2 sets of blood cultures prior to the antibiotic administration, administer IV antibiotics within first 1 hour whenever it is possible. If patient is hypotensive or lactate greater than 4, give isotonic IV fluid challenges where 30 ml per kg. So resuscitation, like if BMI is around 30, so here the weight related resuscitation is very helpful. So and coming to the next 6 hours, in the first 6 hours, remeasure the lactate if the initial lactate is greater than 2 or increasing. If the patient is hypotensive or lactate is greater than 4 in first 6 hours, administer IV vasopressors as needed to maintain the MAP of 65 mmHg. So IV fluids. So here the Clover's trail, it is compared like restrictive versus liberal fluid strategies in patients with sepsis-induced hypotension. So after receiving an initial fluid bolus before randomization, patients randomized to restrictive fluid strategy. So experienced similar mortality and secondary outcomes as the patients randomized to liberal fluid. An updated meta-analysis of 13 trails comparing lower versus higher IV fluid volume found no statistically significant difference in all cause mortality or serious adverse events. Taken together, a liberal fluid strategy does not appear to be associated with higher or lower mortality compared with a restrictive fluid strategy. Early and adequate IV crystalloid fluid administration remains a crucial component of resuscitation of patients with sepsis and septic shock. In the absence of better evidence, we recommended timely administration of 30 ml per kg IV crystalloid fluid bolus for patients who do not have contraindication to administration of that fluid volume and who have evidence of hypotension or hypoperfusion. So patients with risk for fluid overload, updates to CMS, so allow for administration of less than 30 ml per kg in specific situation, such as when there is concern for fluid overload. In both lesser volume and the rationale are documented. So example, if 1 liter IV fluid administered rather than 30 ml per kg due to concerns for volume overload in the setting of severe congestive heart failure. The SALTED study published in 2018 compared balanced crystalloids like ringalactate solution or plasmalate with sodium chloride solution 0.9% in ED patients who were subsequently admitted to non-ICU bed. So in the SALTED trial study, it found the decreased major adverse kidney events in patient receiving balanced crystalloids, though there was no difference in hospital-free days between the two groups at 28 days. The SMART trial found that the use of balanced crystalloids resulted in a lower rate of the composite outcomes of death, new renal replacement therapy or persistent renal dysfunction in 30 days. So a pre-planned secondary analysis found lower 30-day mortality and greater number of vasopressor free among critical days. So when available, balanced crystalloids than 0.9% sodium chloride solution should be used for IV resuscitation in patients with sepsis. So here, than only giving in normal saline to the patients with sepsis or septic shock, we can give the balanced fluid with lactate, plasmolite, and 0.9% sodium solutions. Then the fluid reassessment should be frequently done in ER while giving the fluids in the patient with sepsis or septic shock. The fluid administration should be tailored to patient's fluid volume status. So point focus in conjunction with inferior vena cava IVC ultrasound is another approach familiar to many emergency clinicians. So we can give IVC guided fluids. So these are the prioritizing antibiotics, what should be used in the suspected infections. So the infections like lung infections like pneumonia or community acquired non-severe pneumonias. So you can go with ceftriaxone 2 grams IV plus azithromycin 500 mg IV orally or doxycycline 100 mg IV. Or with the penicillin anaphylactic patients, you can go with levofloxacin. So in additional circumstances, prior MRSA respiratory isolate add vancomycin. So prior pseudomonas respiratory isolate use cefepime 2 gram IV in place of ceftriaxone 2 grams. So in severe community acquired pneumonia, you can go with the same thing like ceftriaxone 2 gram IV plus azithromycin 500 mg IV or orally, or doxycycline 100 mg IV. So in penicillin anaphylactic patients, again, you can go with levofloxacin 750 mg. So in Pseudomonas respiratory infections, you can use cefepime 2 gram IV in place of ceftriaxone. So then any intra-abdominal sepsis suspicion, you can give ceftriaxone 2 gram IV or metronidazole 500 mg IV you can give. Or in patients with penicillin anaphylactic patient, you can give levofloxacin 750 mg plus metronidazole 500 mg. Then suspicion with urinary tract infections in the patients. In those patients, you can give ceftriaxone 2 grams IV, or with penicillin anaphylactic patients, you can go with ciprofloxacin 500 mg IV. Then coming to the pelvic or pelvic pathal sepsis or pelvic inflammatory disease sepsis. So you can go with cefoxitin 2 gram IV plus doxycycline, or then you can go with in penicillin anaphylactic patients, you can go with clindamycin. So then coming to the intravascular or catheter-related bloodstream infections, the recommended antibiotics would be like vancomycin 20 to 25 mg per kg IV plus cefepime 2 gram IV. Or penicillin anaphylactic patients, you can go with vancomycin plus azithromycin. So in cardiovascular, where the patient is suffering from endocarditis or valvular infections, you can go with vancomycin or daptomycin. Daptomycin 8 to 12 mg per kg plus cefepime 2 gram IV. So in penicillin anaphylactic patients, vancomycin 20 to 25 mg per kg plus gentamicin you can give, that is 3 mg per kg. So coming to the soft tissue infections, then you can go with vancomycin 20 to 25 mg per kg. And then in suspected meningitis, you can go with ceftriaxone 2 gram IV plus vancomycin 20 to 25 mg per kg IV. Or in penicillin anaphylactic patients, you can go with vancomycin 20 to 25 mg per kg IV. So coming to the vasopressors and inotropic supports in sepsis or septic shock patients. So here, the predominantly the central venous axis will be more beneficial for the patient over here. So here comes the first vasopressors are like noradrenaline will come in the first time, that is 0.05 mcg per kg per minute. That is like 4 to 6 mcg per minute, titrated by 2 to 6 mcg per minute. It has more alpha adrenergic properties than beta adrenergic effects, but it reliably increases systemic vascular resistance while supporting cardiac function. So coming to the norepinephrine versus dopamine, dopamine has dose-dependent effects on dopaminergic beta 1, beta 2, and alpha 1 receptors. Patients compared with norepinephrine and dopamine in undifferentiated shock demonstrated an increased rate of arrhythmias with dopamine, as well as increased mortality in patients with cardiogenic shock. So dopamine is not recommended as vasopressor for sepsis-related hypotension or hypoperfusion. So then coming to the vasopressin, after the norepinephrine, vasopressin comes the second line for septic shock. So vasopressin is a non-adrenergic vasopressor that causes vasoconstriction and increased systemic vascular resistance by stimulating V1 receptors in vascular smooth muscle cells. It also acts as V2 receptors in the kidney. The vasopressin versus norepinephrine as an initial therapy in shock in a vanished trail failed to demonstrate the benefit to vasopressin titration with regard to the renal outcomes in the septic shock. Vasopressin does not appear to offer mortality benefit, impact new onset arrhythmias, or definitively improve kidney function as a single first line agent. So the vasopressin dose would be 0.03 units per minute IV uh, as a second line agent for after norepinephrine initiation has been shown to reduce the dose of norepinephrine required. So then comes to the after the vasopressin, then comes epinephrine, that is 0.02 to 0.05 mcg per kg per minute, and then comes to the dobutamine, that is 2 to 5 mcg per kg per minute. So here in the septic shock, the first priority for inotropes or vasopressors goes to noradrenaline, then goes to vasopressin, then goes to epinephrine, and then dobutamine. So as we spoke earlier, so in recent studies, the corticosteroids are also helpful in septic shock to improve the BP. So if the BP is not improving despite giving fluids, despite giving vasopressors or inotropes, so you can give, or you need to give hydrocortisone 50 mg, that is every 6th hourly, or 200 mg per day as an infusion. So additional fluorocortisone shows improved outcome. So in special population, elderly patients with septic shock have worse outcomes, likely due to chronic inflammation, impaired cardiovascular function, and differing inflammatory responses compared with younger patients with septic shock. So in patients with cirrhosis, decreases in blood pressure and platelet count, along with tachycardia and impaired lactate clearance, could be misinterpreted as normal physiological variations rather than correctly identified as sepsis. In patients with ESRD, bacteremia is common, and one must remain vigilant for sepsis from intravascular devices. Large frequent fluid shifts may limit the patient's physiologic response to acute illness. So the 5 things that will change your practice is the first thing is sepsis is infection plus organ dysfunction and is not synonymous for CIRS. However, maybe some utility of CIRS news score or mu score for initial sepsis screening. Identifying and achieving the infection source control can improve the patient outcome. Early appropriate broad spectrum antibiotics for critically ill patients with sepsis confers mortality benefit. Patients predisposed to fluid overload, that is like congestive heart failure and end-stage renal disease, may benefit from fluid resuscitation in septic shock and should be treated with an individualized clinical assessment to guide fluid resuscitation. Balanced crystalloid fluids are likely superior to 0.9% MS. So here comes the clinical pathway for sepsis screening in the emergency department. So, whenever the infection suspected in the patient presenting to ED, if there is an infection, then you need to check for evidence of any organ dysfunction. There is no organ dysfunction, monitor the patient clinical condition and reevaluate the patient if sepsis is clinically indicated. So if there is any end organ dysfunction, continue to treat as sepsis, go to clinical go for clinical management. There is in the first beginning itself, if there is no suspicion for the sepsis in the patient presentation, so then assess for the causes of chief complaints, and any furtherly if you're suspecting for infection, then reassess the patient. So once you confirm that the patient is having sepsis, so then you need to check for all these things, like if the patient is in septic shock, or like check for the lactates, take for take blood cultures, keep cardiac monitoring, maintain SpO2, give the antibiotics in less than 3 hours for sepsis, and if it is septic shock, in less than 1 hour. So then fluid resuscitation, monitor fluid balances, initiate, see the source, find the source, and then give the treatment accordingly, and continuously reassess the patient regarding sepsis, and maintain the target BP is MAP greater than 65 mmHg. Then coming to the pitfalls. So the first thing is I prioritized intubation without optimizing hemodynamics because the patient was altered and not protecting the airway. Here in sepsis, the patient might come with altered mental status. So with the initial resuscitation, the patient altered mental status might get better. So if you're suspecting any sepsis with septic shock with the altered mental status patient, first prioritize the sepsis treatment and give the fluid resuscitation and antibiotics and all. If still patient continues to be in altered mental status and the airway is not protecting, then then go for the intubation. Then the second point, I did not think the patient was septic because he was not hypotensive. So the hypotensive is not only the thing to see. So you can see tachypneic, altered mental status, tachycardia in the patient, fever. So all these criteria is to be noted. And the third point, I was afraid to give fluid bolus because the patient had congestive heart failure. So in the congestive heart failure also, we can give the fluids to the patient like up to 300 ml or IVC guided fluids we can give. So then coming to the fourth point, I forgot to review past medical history and prior culture results prior to the antibiotic selection. So you need to know the past medical history, and his prior culture reports might be resistant to some antibiotics which we are giving, or we need to see the patient is sensitive to which kind of antibiotics. So accordingly, we need to give the antibiotics. So always check with the previous reports. So I called the cardiologist because the patient troponin was elevated. So in patients with sepsis and septic shock, the baseline troponin will be elevated. So you need to see regarding that also. So sixth point, I did not reassess the patient. So whenever you're giving the fluids or you're managing the patient with sepsis and septic shock, you need to reassess the patient for every 15 to 20 minutes. You need to monitor the BP. You need to check the altered, like if the patient is presenting with AMS, you need to check the mental status of the patient. You need to check with heart rate. You need to check whether the patient is maintaining SpO2 or not. You need to continuously reassess the patient. So coming to the seventh point, I found urinary tract infection and I treated it. I did not realize the patient also had renal sepsis. So there might be both the things with the patient. So you need to check all the things. So then coming to the eighth point, I ignore best practice advice alerts in the EMR because they are usually wrong and alert too often. So you need to check all the advices and all. So coming to the ninth point, I did not fully undress the patient, so I missed the necrosis. So whenever you are suspecting any sepsis patient, you need to see any other source of sepsis infection is there or not. Or you might be suspecting some urosepsis and patient might be having some gangrene or necrosis over the foot or something. So you need to interest the patient. You need to see all possibility sources of infections. So coming to the 10th point, the patient did not meet this criteria, so I did not think she was septic. As I earlierly told, so the CIS criteria is not only the basic thing to identify the sepsis. So here are a few case scenarios. So how they treated, and let's go with that. So a 40-year-old woman with no past medical history presents with 3 days of fever, chills, dysuria, and flank pain. So her initial vitals in ED are like 38.5 degrees of temperature, and then 120 BPM heart rate, and then blood pressure of 135 by 82, and respiratory rate of 18, and SpO2 maintaining 95%. She's speaking in full sentences, demonstrating normal mentation, and is not respiratory distress. Her lungs are clear to auscultation. Her abdomen is soft and minimally tender over a suprapubic region without rebound or guarding. With right costovertebral angle tenderness. She has brisk capillary refill. The patient has no recent hospitalizations. You believe she looks clinically, but you wonder how concerned you should be about sepsis. So here, coming to identify the sepsis, what are the positive signs we can see? Like the patient is having fever and then tachycardia. So her BP is normal, so there is no shock. There is her respiratory rate is good, her saturations are good. So there might be sepsis because of fever and tachycardia. So you can go for further evaluation. So for the further evaluation, they have done some abdominal screening and then some urine analysis which showed the nitrate positive. So initially they have treated with 1 liter IV crystalloid fluid bolus and acetaminophen for her fever. Then she improved. Her vital signs normalized with antipyretics and fluids. She had an infection but no organ dysfunction. Hence, in her abdomen pathology revealed for her pyelonephritis. So they have discharged with the patient with some oral medication and antibiotics. And then coming to the second case, a 63-year-old man with past medical history of right knee replacement 3 months ago, diabetes mellitus, and then hypertension, presents to ED with fever, cough, and dyspnea. His initial vital signs are temperature of 38.5 degrees centigrade, heart rate of 112, BP of 102 by 68 mmHg, respiratory rate of 22, and saturations of 93 room air. He's alert but thinks in 1997. Physical examination reveals rales at the left lung base, no wheezing or respiratory distress, tachycardia, a benign abdomen, and well-healing surgical lesions. So laboratory findings shows TLCs of around 14,000 with 5% anemia, platelet count of 130,000, and then creatinine of 1.5 where baseline is 0.85, and serum lactates of 2.5. Chest radiograph confirms left lower lobe infiltrates. After receiving ibuprofen and acetaminophen, the patient feels much better and requests to be discharged. His confusion has now resolved. He is oriented to person, place, time, and situation. The nurse asks whether she can remove the IV for the patient to be discharged. But something worries you. So here the patient presented with fever, tachycardia, and then saturations are also about 93 with some hypoxia is presented, and patient presented with altered mental status with raised TLC count and baseline AKI. So here, based on the history of recent hospitalization, the potential healthcare associated infection you can suspect. So possibly here you can suspect sepsis infection. While awaiting with the laboratory results that might identify end organ dysfunction, you empirically started some sepsis management. You administered IV ceftriaxone and vancomycin to cover the potential pulmonary sources, as well as 30 ml per kg fluid IV boluses, crystalloid boluses are given. His creatinine was 1.5 from the baseline of 0.9, consistent with end organ dysfunction from acute kidney injury. His blood pressure improved to 115 by 76 after IV fluid administration, and his repeat lactates has downtrended from 2.5 to 2.1. But he was noted to be requiring 3 liters of oxygen support and still keeping having like 23 breaths per minute. So he was admitted in the room in view of sepsis and discharged from the hospital on day 3. So there's one more case scenario. So a 35-year-old man with past medical history of poorly controlled diabetes mellitus and IV drug use presents to ED for right axillary pain and swelling. So the paramedics report that he frequently presents for poorly controlled diabetes he continues to complain of 20/10 pain despite 150 mcg of pre-hospital IV fentanyl. Pre-hospital vital signs include temperature of 39.4 degrees centigrade, heart rate of 135, BP of 82/52, respiratory rate of 30 breaths per minute, and oxygen saturation of 88% on room air. His initial glucose level is 342 mg per dl. The patient is alert, oriented, but screaming in pain as he is transferred from EMS stretcher. Physical examination reveals tachycardia, delayed capillary refill time, that to 4 seconds, tachypnea, clear breath sounds, and erythema, swelling and crepitus overlying the right axilla and chest wall. So after 2 liters of isotonic crystalloid administration, EMS repeat blood pressure is 70/45. You consider the best antibiotics under uncertain whether you should initiate vasopressor or not, attempt another fluid bolus, or both simultaneously. Here, as the patient is having fever, tachycardia, hypotension resulting in like shock, tachypnea, and hypoxia. So the patient is definitively in septic shock. So here initially the EMS persons already have given the 2 liters of IV crystalloid fluid boluses. Still the BP is not improved. So you need to consider to give vasopressors, or vasopressors, like the first line comes with the noradrenaline, and then to maintain the BP about MAP of 65 mmHg. So, and then the antibiotics also should be started. So here predominantly you can go with vancomycin and piperacillin tazobactam, like as the patient is having underlying skin infection. So, and then you can go with the IV steroid also, like as the patient is having persistent shock. So in you can consult the general surgeon people for the underlying skin tissue infection, and then here the patient was admitted to ICU for the following debridement in the hospital course. So coming to the pearls, so patient who have a suspected source of infection and identified organ dysfunction or elevated lactate levels should be treated as having sepsis, regardless of whether they meet initial sepsis screening criteria or whether they triggered a best practice advisory. Infectious source identification and control should be achieved as rapidly as possible. Current literature remains neutral regarding restrictive versus liberal IV fluid strategies. Fluid administration should be tailored to patient's volume status. Dynamic assessment measures are preferred. Based on current literature, it may be reasonable to promptly address the hemodynamic instability with a hybrid approach of IV crystalloid fluid administration for volume resuscitation while simultaneously administering vasopressors for hemodynamic support, with goal of weaning vasopressors as fluid resuscitation is accomplished. So here are the few updates of this 2026 sepsis updates. So if the sepsis is definitely there, if then administer antimicrobials within 1 hour if the shock is there. So if shock is not there, administer antibiotics ideally within 1 hour of recognition. So if you are not sure about sepsis, and if it is like sepsis, possibility of sepsis, you can give antibiotics up to like within 3 hours. So here are the few updates, like coming to the first thing, like screening and early identification of sepsis. Here more than SOFA and CIS criteria, the updated version shows more specificity with news and news 2 and news scorings. So avoid QSOFA alone. So you need to follow the sepsis protocols and QI programs. So coming to the hospital, you need to first collect the blood cultures of 2 sets from the patient within 1 hour. So within 1 hour, you need to start with antibiotics also. So, and then de-escalation of the antibiotics according to the source. And source control should be done within 3 hours of the arrival of the patient. So then coming to the hemodynamic management, fluid of 30 ml kg per kg crystalloids within 3 hours should be given. And then if still the BP is not improving or persistent hypotension or shock is there, you need to start with first line vasopressors, like, excuse me, noradrenaline. And then you need to maintain the MAP of 65 mmHg and frequent reassessment should be done. So continuous monitoring of the sepsis and septic shock patients, like you need to check for the lactate levels. If the lactate levels from the initially are elevated, you need to check it for every 2 hours. So you need to check clinically the patient and you need to check for any organ dysfunctions or not. So in emergency, the sepsis patient should be treated immediately. Early antibiotics is early life-saving. Avoid resuscitation delay. And then from the respiratory support, first oxygen support, then high flow nasal cannulas, then coming to the NIV, then coming to the mechanical ventilatory supports. So in ARDS patients, low tidal volume is preferred. And then in ARDS patients or severe ARDS patients, prone positions are preferred. So as we already discussed in adjunctive therapies, you can give corticosteroids in refractory shock patients. Like if the patient is not improving shock despite giving fluids and vasopressors, and then you need to check for DVT prophylaxis. And then you need to see for glycemic controls. So in sepsis with septic shock patients needing long hospitalizations and all, better to shift to ICU, from ICU to ward, then discharge. So these are the main things to be followed. So in the updated version of the Sepsis 2026 guidelines, the antibiotics should be given as early as possible. Prior if patient is having like severe shock, then in 30 minutes, then if the patient is having sepsis with septic shock, the antibiotics can be given in a time period of 3 hours to prolong the antibiotic mechanism over the infection. So in the new guidelines, you can give the antibiotic over 3 hours. Thank you.
Yeah, Dr. Swarna, you be on the line. So once we finish the second topic, so we can take the question.
Sure, sir.
Yeah. Kartika?
Yes, sir.
Yeah, you can go ahead.
So, good evening, everyone. So, coming to the next topic, sir, I'm audible, sir.
Yes, yes.
So we have already discussed about the sepsis, the updates and all. So coming to the next topic, that is emergency department management, evaluation of severe traumatic brain injury. So I'm myself, Dr. Kartika Pillai. I'm a second year DNB resident in Yashoda Hospital, Malakpet. So this session will be moderated by Dr. Kondil Raghu. He's an HOD Emergency Medicine, Yashoda Hospital, Malakpet. So coming to the topic proper. So first coming to the epidemiology of traumatic brain injury. So there are approximately 1.7 million traumatic brain injuries are evaluated annually in US hospitals. So the highest instances occurring in case of children who are under 5 years of age and adolescents at the age of 15 to 19 years and adult over 75 years of age. So this mostly higher incidence occurring in extremes of age. Why it is important is that in 43% of the patients who are hospitalized for the TBI, they have experienced some long-term residual disability, which either due to there can be including physical disabilities, cognitive and psychosocial impairments are there. That's why it is important to discuss about the topic. So coming to the etiology of TBI, so in that the falls are the leading cause of TBI, which is responsible for about 50% of TBIs in patients in the extremes of age, that is less than 17 and 65 years of age, and 81% of all TBI related ED visits. So other leading causes that we see commonly in the EDs are the RTAs, the motor vehicle crashes, the blunt strikes with objects, sports injuries, the non-accidental trauma, and the blast injuries. So the physical mechanism of injury either can be an impact loading, either can be an impact or it can be an acceleration deceleration forces, which can result in a Cooper counter Coop injuries, which will predict the pattern of the brain trauma. So the most common etiology will be the falls, which is a leading cause. Next only the RTAs will come. Then coming to the primary pathophysiology. So the primary brain injury, it's a direct result of the initial mechanical force or the impact. Due to the initial impact, there can be primary brain injury, which can either an open injury or it can be closed injury. Open injury means it involves skull fractures or there can be penetrating trauma. In case of closed injury, there will be having some contusions or some intracranial hemorrhages will be there. So these severity will influence the depth and duration of the immediate neurological impairment. So what is more important than the primary physiology is the secondary pathophysiology that we can be prevented in our ED. So in the secondary injury, it develops over hours or days following the initial insult, which lead to worsening outcomes. So the mechanism can be either due to the worsening cerebral edema or due to the main important culprit, that is an elevated ICP, or it can be due to a reduced cerebral blood flow, which can further cause a cerebral hypoxemia. So these all will cause a secondary injury. So there can be a cellular cascade event which will trigger the glutamate excitotoxicity. There can be an oxidative stress which further lead to a lipid peroxidation, further leading to neuroinflammation and apoptotic cell death. So in the secondary pathophysiology, when there's a secondary insult that like a hypoperfusion, if the patient is having some hypoxia, hypoglycemia, or hypotension, it can further impair the pump dysfunction. Sodium potassium ATPase pump will be disrupted, which will further lead to a depolarization, which releases the glutamate, which is an excitatory neurotransmitter, and there can be an opening of voltage-gated calcium channels, which all together lead to an increased calcium, intracellular calcium, further leading to a protease activation and cytoskeletal disruption, further leading to neuroinflammation and an apoptotic cell death. So this is a mechanism that is causing the secondary injury. So from our point, we can break the chain at the top level before the excitotoxicity begins. We can prevent the hypoxia and hypoglycemia when the patient coming to the ED, so that we can prevent the secondary injury. So coming to the primary impact injury. So in case of closed injury, the most commonly what you're seeing in EDs are the intracranial hemorrhages. So there can be a first, we'll be discussing about the traumatic SAH. So there can be traumatic and atraumatic SAH will be there. So in case of traumatic SAH, it is occurring due to the small capillary tear, which will leading to leaking of blood in the subarachnoid space. So how to differentiate between atraumatic and traumatic is, in traumatic, the blood will be over the outer convexity of the cerebral cortex. Unlike in case of aneurysmal SH or the spontaneous SH, it will be more commonly seen near the basal cisterns. So how to identify in a CT? There will be hyperdense blood will be there filling the sulci and fissures and cisterns. So this is a CT image showing an SH. You can see the hyperdense filling that is seen in the cisterns and fissures. Then coming to the second one, that is the EDH or the epidural hematoma. So EDH means there will be bleeding outside the dura mater. That is mostly due to the destruction of the middle meningeal artery and its branches. So in the CT, it will appear as a biconvection shaped or a lens shaped. The thing is, it is restricted by the suture line. The dura will be attached to the suture, so it will be restricted by the cranial suture lines, and there's a chance it may cross the midline also. So that's how we'll differentiate the epidural hematoma from an SDH. So this is a picture showing a CT image showing an EDH, which is a biconvex in shape or lens shape, and it will be limited to the suture lines, but it can cross the midline. Then coming to the third one, that is the SDH or the subdural hematoma. So here the bleeding will be due to the tear in the bridging veins between the dura and between the brain and the dura mater. So there can be an acute SDH or a chronic SDH. In case of acute SDH, the presentation can be acutely, which lead to rapid development of neurological symptoms, or it can be chronic presentation with a gradual presentation. So on the CT, it will be seen as a crescent-shaped blood, and it does not cross the midline, and it not limited by the cranial sutures. So it is inside the dura mater. So it does not cross the midline, but it is not limited by the cranial sutures. So this is an image showing the subdural hematoma, where it is a crescent shaped. So first one is an acute one, and second one is a chronic one. So in acute one, we can see the hyperdense lesion. Over the time, it will become hypodense. Then other injuries, the other primary injuries can be a contusion or a diffuse axonal injury. So contusions, either it can be a Cook contusion or a counter Cook contusion. In case of Cook contusion, it occurs directly at the impact site. There will be a Cook contusion. So opposite to that, there will be counter Cook contusion when the brain hit the irregular skull surface. Then coming to the diffuse axonal injury. So the axonal injury, the diffuse axonal injury occurs because of the shearing, a twisting, or a stretching force which is applied to the neuronal axons, which is typically occurring at the gray and white matter junction. So this dye, it may not be apparent on the initial imaging. So initial CT or MRI may not interpret an diffuse axonal injury, but it can evolve through the secondary injury mechanism leading to axonal death. So when there is an injury, axonal injury is there, there will be validin degeneration, further causing scar, which lead to axonal death. So these are the primary injuries that we have discussed. So there can be traumatic SH, SDH, or EDH will be there, and contusions and diffuse axonal injuries. So how will you classify the traumatic brain injury? So there is clinical classification and radiological classification is also available. According to clinical, we will differentiate by the GCS, Glasgow Coma Scale. So the severity can be classified by, if the GCS is between 13 to 15, means there will be a mild TBI. That is, there will be only a brief period of LOC will be there. If it is 9 to 12, then it will be moderate. That is, there will be a prolonged period of unconsciousness will be there. If it is 3 to 8, then it will be severe TBI, often indicating a coma. So if it is less than 8, it is known as a severe TBI. Then radiological classification is the primary imaging modality for all TBI cases will be a non-contrast CT scan. So in that, two scoring systems are there, Marshall CT classification and Rotterdam CT score. In Marshall CT classification, it evaluates the diffuse injuries and mass lesion, and it will determine the 6-month mortality risk. In case of Rotterdam CT score, it will assess the severity and the prognosis. So coming to first one is a Marshall CT classification of traumatic brain injury. There are 6 classes are there. So in category 1, if it is a diffuse injury, means there won't be any visible intracranial pathology will be there on CT. Then the 6-month mortality risk will be the 10%. In diffuse injury 2, there will be midline shift of 0 to 5 mm will be there. Rest everything will be normal. Then the 6-month mortality risk will be 13%. In diffuse injury 3, the midline shift will be there about 0 to 5 mm with the basal interns will be compressed or a complete effacement will be there, which lead to a 6-month mortality risk of 66%, 33%. Then diffuse injury 4 means there will be midline shift of more than 5 mm will be there. Then it will be coming under the diffuse injury 4. There the 6-month mortality rate will be the 56%. Then if there is any mass lesion is there and it is surgically evacuated, then it will come under the category 5 and the mortality risk will be 35. It will decrease to 35%. If there is a non-evacuated mass lesion will be there, that is not surgically evacuated, then the mortality risk will be 91%. So this Marshall CT classification is to assess the 6-month mortality risk. So it will be more risk if the midline shift is more than 5 mm. Then coming to the Rotterdam CT score for the traumatic brain injury, here we will be, here the categories will be the basal cisterns will be there, midline shift, epidural mass lesion, and interventricular blood or a traumatic SH. These are the categories. So if the basal cistern is normal, the point is, it will be given 0 point. If it is compressed, 1 point. If it is absent, then it will be 0 point, 2 points. Then in case of midline shift, if there is no shift or the shift is less than 5 mm, then the point will be given as 0. If the midline shift is more than 5 mm, then 1 point will be given. So then epidural mass lesion, if there is any mass lesion, if it is present, it is 0. If it is absent, it is 1 point. And interventricular blood or traumatic SH, if it is absent, it is 0. If it is present, it is 1. So on to this, we'll add 1 plus. So as the score increases, the outcome will be the severity and the prognosis will be the worst. So these are the classification according to the CT for the traumatic brain injury. So now coming to the differential diagnosis. So if a patient coming with an altered mental status, we have to evaluate both, not only the primary injury, we have to also assess the precipitating factors that have caused the trauma. And we have to also, in this traumatic brain injury cases, we have to look for any concomitant emergencies, like if there is any dysarrhythmias, if there is any simultaneous, any ischemic stroke is there, seizures or any metabolic irregularities like hypoglycemia. So everything should be addressed. And in case of there can be an opioid overdose, alcohol or illicit substance intoxication can be there, which can severely confound the initial neurological assessment and GCS scoring. So if there is any substance abuse or alcohol intoxication, anything is there, which will further decreases our GCS, and it will further interfere with our initial neurological assessment. So these should also be kept in mind when you're evaluating the patient. Then coming to the pre-hospital care and stabilization goals. So as an ED physician, so our priority will be the airway, breathing and circulation. And we have to prevent the secondary insult. So hypoxia and hypotension, if there is any hypoxia and hypotension, it must be aggressively avoided because each can further lead to a significant increase in the morbidity and the mortality. And in case of pre-hospital care, what is important is we have to notify the hospital prior to the transport of the patient. So the pre-hospital notification is also crucial to ensure the direct transport to a specialized center with immediate CT and neurosurgical care and ICP monitoring capabilities. We have to ship the patient to a hospital with the neurosurgical care. Then coming to the ED management. So in the ED, we have to first maintain a strict cervical spine immobilization. The patient is having a severe traumatic brain injury is there. We have to stabilize the cervical spine until the injury is excluded clinically or radiographically. Then we have to secure the airway if the patient is having a GCS of less than or equal to 8, because there's a chance of aspiration is also more. Then we have to take first airway, breathing and circulation. Then we have to take the history of the patient, the duration of symptoms. If there is any transient LOC to unresponsive state, we have to take the proper history. Then we have to obtain a reliable medication history also. If the patient is using any antiplatelet agents or any anticoagulants on use, because of the need for any rapid reversal. If there is any ongoing bleed, anything is a need, it is required for the rapid reversal. Then we have to look for the first, after the history and the past history, then we have to assess for any physical examination findings. So the main physical examination, the significant findings are the battle sign or the raccoon's eye, which indicate a basilar skull fracture. And we have to look for any CSF drainage from the otorrhea or rhinorrhea is there, because it further increases the meningitis risk. Then we have to assess the pupil. If there is any fixed unilateral dilated pupil is there, which indicate an ipsilateral herniation or an oculomotor nerve compression. Then we have to look for any abnormal brainstem reflexes, which indicate a subcortical injury. So if there is any bruising, battle sign means if there is any bruising behind the ear, or if it is beneath the eyes, it is known as a raccoon eyes, or any hemotympanum, which indicate a basilar skull fracture. Then we have to look for any otorrhea or rhinorrhea, which is positive for the CSF fluid, because if there's a CSF leak, there's a higher predisposition for the meningitis. Then we have to look for any ipsilateral fixed unilateral dilated pupil, which indicate an ipsilateral herniation, or there will be a hemorrhage, which is causing compression over the oculomotor nerve. Then we have to look for any Horner's syndrome, which indicate a carotid artery dissection, any abnormal brain stem reflexes are there, or any focal deficits are there, any abnormal sensation. If there's an abnormal sensation, it point towards some localization to central versus peripheral nervous system injury. So depending upon the distribution, we have to differentiate whether it is a central nervous system or a peripheral nervous system injury. So these are the findings we have to assess in these patients. Then the important thing is the recognition of Cushing triad. So in the ER, what we are seeing, the Cushing's triad is the elevated BP with a decreased heart rate and the irregular or decreased respiration. The thing is, it is a very late clinical manifestation. It is seen after significantly elevated intracranial pressure. But the specificity is very high, that is about 93%, and it has a very low sensitivity. So the Cushing's triad, what we are seeing is a late sign of an raised intracranial pressure. Then coming to the imaging modalities. So the main primary or the gold standard imaging modality will be the non-contrast CT scan. So it is a gold standard to identify any hemorrhagic lesions are there or that require any immediate surgical intervention. It is ideally we have to obtain the non-contrast CT within the first hour of presentation if there is a moderate to severe TBI. And we have to repeat the CT if there is an indication, like if there is an acute change in neurological examination, or if there is any drop in GCS is there, if the pupil is anisocoria, or if there is any seizures, or if there is any signs of brain herniation, we have to repeat the CT. So how will you interpret a CT? So there is an triple BC approach is there, means A means air. So we normally where we will see air is in the ethmoid sign, in the air spaces, like in the ethmoid, frontal, maxillary sinus, we will see the air, which will appearing as a black in color. So if there is an abnormal air in the cranial vault, it will suggest a fracture. And we have to look for any skull or the facial fractures using the dedicated bone windows. Then we have to see if there is any intracranial bleed, anything is there. Already we have discussed how we will differentiate the epidural, SDH and SH in the CT. So we have to look for any bleed. Then we have to look for the brain, that where we will see any loss of gray and white differentiation, which will indicate concern for the significant cerebral edema. Then we have to look at the CSF spaces, mainly the sulcus, fissures, cisterns, for any compression or if there is any hydrocephalus. And if there is any midline shift of more than 5 mm, it is require an emergency neurosurgical evaluation and evacuation, regardless of the patient's apparent clinical stability. So this is the image showing a CT interpretation of using a triple V seeds targeting system. So here air, we can see the in the black color is the air, which is normally seen in the sinus spaces. If it is seen in the brain, it is indicate a fracture. Then we have to look for any bone. In the bone, we have to look for any skull or facial fractures. Then we have to look for any EDH, SDH, or any intraparenchymal bleed. Then in the brain, we have to look for any gray and white difference, loss of gray and white differentiation, which will indicate a cerebral edema. Then we have to look for the CSF spaces also to look for the any compression of ventricles or any hydrocephalus. Then coming to the non-invasive neuromonitoring, ultrasound and the pupillometry. So the main thing is we have to assess the patient is having any raised intracranial pressure. So what we're seeing in Cushing's triad, it will be a late manifestation. So in there are some non-invasive neuromonitoring are there. That is optic nerve sheath diameter, optic disc elevation, and automated pupillometry. In optic nerve sheath diameter, it is a point of care ultrasound that we have in our ED. So here we will look for the optic nerve sheath diameter. If it is more than 5.8 to 6 mm, so clear cutoff, it is not, the cutoff is not clear. So mostly if it is more than 5.8 to 6 mm, it will suggest an raised ICP of more than 15 mm. Because if there is any raised intracranial pressure, it will be directly reflected in the optic nerve sheath. Then we have to look for any optic disc elevation. If the optic disc elevation due to this back pressure, there can be optic disc elevation also. If the elevation is more than 0.04 centimeter, which indicate a raised ICP of more than 22 millimeters of mercury. Then there is automated pupillometry is also available. So normally what you're using is using a pen torch. We'll assess the pupils of the patient. If there is any pupil size, we will check the symmetry and the reactivity. So for the better assessment, there is some automated pupillometry is available, which is a portable infrared devices, which will provide a quantitative assessment of the pupil size, the symmetry and reactivity, which offer an early detection of any brainstem dysfunction. So this is the non-invasive and neuromonitoring devices. So here we can see, this is what we see using a in the point of care ultrasound. So from the optic disc, we will measure about 3 mm. From the 3 mm, we will horizontally measure the optic nerve sheath diameter. If it is more than 5.8 to 6 mm, it indicate a raised ICP. So the third image is it's an automated pupillometry that is available for a better examination of the pupil. Then coming to the newer biological markers of the traumatic brain injuries, there are main 4 markers are there. One is a neuron-specific enolase, S100B, ubiquitin carboxy hydrolase L1, and tau. These are the newer biological markers. So the neuron-specific enolase, it is a glycolytic enzyme which is found in the neurons. The thing is, it will rises within 12 hours and it will declines over hours to days. It is mostly elevated in CSF as well as in serum, which indicate an increased mortality risk. If there is a raised neuron-specific enolase, it indicates a higher mortality risk. But the thing is, it is also expressed in the RBCs, so there can be false elevation can be there due to hemolysis also. The second one is the X100B, which is a protein that is present, protein from the astroglial cells. The peaks will be within 6 to 24 hours. It indicates a marker of astroglial injury. It also correlates with severity of injury and mortality. Then there is UCHL1, which is a neuronal protein. Its early elevation, there can be early elevation can be seen after injury. The higher levels are also associated with a severe TBI and lower GCS, and it is primarily useful for any acute severe injuries. Then there is tau biological marker. It's a microtubule associated protein in the neurons. It can also be elevated both in acute phase and chronic phases. So it is useful as well as in assessing the acute neuronal injury, or also in chronic condition, like if there's any chronic traumatic encephalopathy, if the repeated trauma is there, in that time it might also be the tau will be useful. So these are the newer biological markers for assessing the traumatic brain injuries. Then coming to the first ever stabilization. So after the AD stabilization ABC, then the first target will be we have to maintain the oxygenation with saturation of more than 90 to 90%, and BP should be maintained more than 100 to 110 millimeters of mercury, and the cerebral perfusion pressure should be maintained between 60 to 70 millimeters of mercury, and the glucose should be maintained 80 to 180. So any further decrease, any hypoxia or hypotension, or if there is any hypoglycemia, or any hyperthermia is there, which will further lead to secondary insult, which will further worsen the outcomes. So in case of airway management and rapid sequence intubation in TBI patients, so the indication will be we have to intubate the patient if the GCS score is less than 8, and the patient that is there's a chance of aspiration and they cannot protect their airways. Here, what is important is there's a higher chance of hypoxia will be there if there is an hypoxia which can further result in a secondary insult. So prioritize the pre-oxygenation to minimize hypoxia, and we have to optimize the hemodynamics prior to the intubation. So the agent which we are preferring is etomidate, which is the induction agent of choice for the because of its hemodynamic stability. The other agents what we can use is ketamine and propofol. But in some studies have shown that if you're using ketamine, there's a chance of increasing the intracranial pressure. So mostly it is avoided, and propofol will decrease intracranial pressure, but the thing is it can further cause an hypotension. So the ideal agent of choice will be the etomidate. Then the paralytic agent of choice, either we can go for a succinylcholine or rocuronium, but succinylcholine we have to be cautiously use because in patients with hyperkalemia, and if there's any muscular dystrophies are there, and in some studies it have shown there is an associated with an increased mortality in some retrospective studies with severe TBI cohorts. So mostly the paralytic agent of choice will be the rocuronium. So induction agent of choice will be the etomidate, and the paralytic agent of choice will be the rocuronium. Then coming to the ventilation strategies, so we have to target a normoxia, that is saturation should be more than 90%, and PO2 should be more than 60 millimeters of mercury, and normocarbia should also be maintained. Why means if there is any hyperventilation or the PCO2 is less than 25 millimeters of mercury, there is a chance of cerebral arterial vasoconstriction, which will further lead to cerebral ischemia. So initially, we shouldn't do a hyperventilation because if there is a raised ICP, we will decrease the PCO2, but it is only a temporary method in case of an acute brain herniation because it can further lead to an arterial vasoconstriction and it can further lead to a cerebral ischemia. Then coming to the hemodynamic optimization, we have to maintain the cerebral perfusion pressure. So if there is any hypotension, it should be aggressively treated with an isotonic crystalloids. Preferably, we can go for it with a normal saline or a blood products to achieve the euvolemia. And if there is any extracranial source of bleeding is there, then it should be corrected. So hypotension should be managed so as to keep the BP above 100 to 110 millimeters of mercury. Then coming to the temperature and metabolic management. So if there is any higher temperature, it can lead to an increased cerebral metabolic demand, which will further lead to a cerebral ischemia. So early or a prophylactic prophylactic hypothermia is also not recommended. So in ideally, we should keep the patient in normothermia, and normoglycemia have to be maintained. And the role of tranexamic acid, so it can be given according to the crash 3 trials. It can lead to within 3 hours of injury. It can lead to a reduction in 28-day head injury related mortality. The indication will be we can give tranexamic acid to a patient with GCS of 8, 9 to 15, and if they're having a bilaterally reactive pupil. In less than into severe TBI, it won't be of much benefit if we give tranexamic acid also. So if the GCS, if there's a moderate to mild TBI is there, we can go ahead with the tranexamic acid also. If the patient presents within 3 hours of injury. Then coming to the TBI associated coagulopathy. So it is present in up to 63% of severe TBI patients upon initial hospitalization. The coagulopathy will further increase the mortality risk to 9-fold and which will lead to a rapid progression of the intracranial hemorrhage. So it is driven by, there can be a tissue factor release into systemic circulation. The coagulopathy can be due to tissue factor release into systemic circulation, or it can be due to a platelet dysfunction, hyperfibrinolysis, and it can be also due to a consumption coagulopathy. So the reversing of coagulopathy, so rapidly identifying, we have to identify if the patient is having any pre-existing coagulation condition is there, if the patient is on any anticoagulant or antiplatelet medication, because if the patient is on anticoagulant medications, it can be reversed by giving a fresh frozen plasma or a prothrombin complex concentrates. And if the patient is on antiplatelet therapy, previously we used to give some desmopressin and platelet transfusion, but the treatment still remains controversial. There has been mixed evidences regarding the outcome benefits. So now coming to the management of an elevated intracranial pressure. So in case of intracranial hypertension, which develops in up to 50% of severe TBI patients despite a surgical intervention, so the treatment is recommended if the ICP is more than 22 millimeters of mercury for about 5 to 10 minutes. So there can be invasive. So the ICP monitoring, there can be invasive ICP monitoring and non-invasive ICP monitorings are there. Non-invasive, we have already discussed about the optic nerve sheath diameter, the pupillometry, and the transcranial or Doppler ultrasound. In case of invasive ICP monitoring, we can either use with a ventricular catheter, or there can be intracranial monitor, or an extraventricular drain is also available. There we can also remove the excess CSF also. So in which all patients we have to do an ICP monitoring. So the ICP monitoring is done if the GCS is 3 to 8 and if there is an abnormal head CT. If the GCS is 9 to 15, that is there is a mild to moderate TBI is there, then head CT should show more than one of the following. That is, if there is any mass lesion of more than 1 centimeter thickness, if there is any more than 3 centimeter hemorrhage, if the basal cistern is effaced, or if there is any midline shift of more than 5 mm, or if there is any post craniotomy status, then these all cases ICP monitoring is important. Then coming to the management of a raised ICP. So these raised ICPs we are managing in tiers. So the tier 0 or the foundational care is we have to admit the patient to ICU. The main thing is we have to elevate the head to 30 degrees Celsius and to maintain a midline positioning. And we have to administer analgesia and sedation. And we have to maintain all the parameters within the normal range. That is, we have to maintain normothermia. We have to maintain the serum sodium of more than 135. And we have to maintain a glucose level between 60 to 180. And we have to maintain the hemoglobin of more than 7 grams per deciliter. So main thing is in the foundational care, we'll admit, we'll give analgesia and sedation, and we have tried to maintain all the parameters within the normal range, and we will elevate the head to 30 degree. If the patient is still having a sustained ICP of more than 22 millimeters of mercury for about 5 to 10 minutes, then we will come to the tier 1. That is, here we will administer the hyperosmolar therapy, that is the hypertonic saline or a mannitol. Then we can also drain the CSF fluid. If there is an extraventricular drain is in place, we can drain the CSF. Then here the PCO2 should be target between 35 to 40. And we have to titrate the sedation so as to reduce the ICP. And we have to consider a repeat head CT. If there is any ongoing bleed, if there is any size is increasing, if there is any further midline shift, we have to see. So for the hyperosmolar therapy, there is two things are available. That is, one is mannitol and the second one is a hypertonic saline. So in case of mannitol, it is an osmotic diuretics. There are two mechanisms of action. One is it decreases the blood viscosity and promote the cerebral vasoconstriction, and is also an osmotic gradient. It also creates an osmotic gradient. So it can be administered IV. It is available as 20 to 25 percentage, and the dose we have to give is 0.5 to 1.5 gram per kg. Here, what is important, what we have to take care is there's a risk of crystallization is there. We have to administer it through a micron filter. and it should be very cautiously used because it's a diuretic agent. It can further worsen the intravascular volume depletion, and further it can cause hypotension and further leading to a reduced cerebral perfusion pressure. So it is not recommended in hemodynamically unstable patients. Then the second one is a hypertonic saline. So hypertonic saline, there also the mechanism of action is it's an osmotic agent. So there will be osmotic shift, that is, it will draw the fluid from the brain parenchyma into the intravascular space. So it can be administered either as a bolus or a continuous infusion is available. The concentration that is available is 3%, 5%, 7.5, and 23.4%. These are the concentrations that are available. In ED, we can give 250 ml bolus of 3% hypertonic saline over 20 minutes, and hypertonic saline of about 23.4% also can be given about 30 ml over 5 to 10 minutes through a central line. According to more studies, it will maintain the mean arterial pressure better than the mannitol. So it is better to give hypertonic saline than the mannitol. So mannitol, because we have to be cautiously used if the patient is having hemodynamic instability, it can further worsen the hypertension. Then the 2 and 3 tiers are, if the patient is having still the ICP is raised, then we have to implement a milder hyperventilation. Here, that is, we will do for hyperventilation. That is, we can maintain the PCO2 between 30 to 35 for a temporary period of time. Then we have to initiate the neuromuscular paralysis, and we have to perform a decompressive surgery to evacuate any mass lesions. Then in tier 3, if still the patient is refractory to intracranial hypertension, then we have to initiate a high-dose barbiturate therapy, that is phenobarbital, and we have to maintain a mild hypothermia, and we have to consider for the further decompressive craniectomy. So these are the steps that we follow in case of the management of raised ICP. Then coming to the other complications of traumatic brain injury. The second one is a post-traumatic seizures. So there can be convulsive as well as non-convulsive seizures can be occurring in a patient with a TBI. The convulsive seizures are about 3 to 4%, and non-convulsive seizures are up to 20%, which will obscure by the clinical examination, and it can further aggravate the intracranial pressure. So there can be an early post-traumatic seizures which is occurring within first to 7 days, and there can be a late post-traumatic seizure that is represents the post-traumatic epilepsy. If the seizure is lasting for more than 30 minutes, it can further result in the secondary cerebral ischemic injury. So for the seizure prophylaxis, we can give the anti-seizure medication like levetiracetam or phenytoin is recommended as prophylaxis for the first 7 days after the injury if the patient is having any moderate to severe TBI. If the patient is, the prophylaxis should be discontinued after 7 days if there is no clinical or EEG seizure activities identified, because there is no evidence supporting the late PTS prophylaxis. So if the patient is, we will start as prophylaxis for the first 7 days. After 7 days, if there is no clinical or EEG seizure activities there identified, we can discontinue the medication after 7 days. So in some meta-analysis, they have demonstrated the phenytoin prophylaxis have a lower risk of post-traumatic seizures. So phenytoin prophylaxis will be better. Then the other complication is a deep vein prophylaxis, DVT. So the immobility, the patient is severe TBI bedridden. So this immobility will further create a high risk of DVT. So here the important is we can to initiate the mechanical prophylaxis, that is compression stockings, sequential compression devices immediately. The pharmacological devices can only be added once the patient brain injury and the bleedings are stabilized. Then only we can give the pharmacological prophylaxis. So first we have to initiate the mechanical prophylaxis in these cases. Then prevention of infection. So here these patients will be a risk of ventilator associated pneumonia and iatrogenic ventriculitis. So in nowadays antimicrobial impregnated catheters are available to prevent the catheter related infection, and previously because of the higher risk of ventilator associated pneumonia, prior to intubation we have to give prophylactic antibiotics. But now, according to current evidences, the routine prophylactic antibiotic for intubation are no longer supported. So there is no benefit of giving any prophylactic antibiotic before intubation in these cases. Then the CSVT or the cerebral venous sinus thrombosis. So the it's a frequently missed complication which can further increase the mortality risk by 10% because here the patient will be having more of headache which will mask the CSVT. So there's a high risk of suspicion is required for patients with multiple skull fractures, particularly those if they're having these fractures are crossing the venous sinuses. So diagnosis primarily via the CT venography. In CT angiography also, it can be seen in CT angiography also. So the management, it remains controversial in the current concurrent hemorrhage. Then, what are the indications for the emergency surgical evaluation? So early neurological consultation is required for all moderate to severe TBI, and we have to do a surgical evacuation if there is an epidural hematoma, if the volume is more than 30 centimeter cube, regardless of the GCS, if there is SDH of more than 10 mm, or if there is a midline shift of more than 5 mm, if there is an intraparenchymal hematoma, which is of diameter of more than 3 centimeter and volume of more than 50 ml, or if there is a more than 5 mm midline shift is there. And surgery is also indicated if there is any further GCS drop is there of more than 2 points, or the pupil is become asymmetric and fixed, or if there is a raised ICP of more than 20 millimeters of mercury. These are all the indication for the surgical evaluation. Then coming to the disposition and the optimal level of care. So first we have to identify the severe TBI, recognize the severity of TBI using the GCS score. Then we have to admit the case in the ICU. For the continuous monitoring, and it requires a continuous neurological monitoring, monitor the brain activity, the vital signs, the GCS, the pupil. You have to continuously monitor the case. Then invasive ICP assessment is required for the selected cases. Then rapid neurological intervention. They should provide an immediate surgical treatment if needed, and we have to transfer if necessary. We have to move the patient to a level of higher level of care if resources are limited. So the critical pitfalls in disposition is one is angering bias. That is, never assume the altered mental status is purely secondary to alcohol, opioid, or administrative mechanism. And adding to that, these intoxications can further severely confound the GCS scoring. So it can further lead to a drop in GCS, and the initial evaluation will also be interfered. Then coming to the delay in the standard of care. We should never delay the life-saving intervention like intubation. If the patient is having altered consciousness, if he cannot provide consent, we should never delay the life-saving interventions. Then ignoring the serial examination. After coming, we'll do an initial assessment. Then we'll fail to repeat the CT or repeat the neurological examination. So failing to repeat a CT scan when the neurological exam is acutely changes can lead to a fatal or unrecognized herniation. So summary is, for a severe TBI management, it requires a methodological approach to assess the ABC, followed by goal-directed therapies to limit the secondary brain injury. And early recognition and surgical indication is important, and the rapid neurological consultation and ICU admission, which significantly improve the patient survival and functional recovery. Thank you.
The wonderful two presentations. So first we'll take the questions from the attendees. Swarna, you are there?
Yes, sir. Yes, sir.
Yeah, the first question for you is RL is being preferred as a guideline. How is it justified compared to the previous guideline?
So in RL, we predominantly, so your question is between RL and NS, which one is preferable and why? So we prefer RL than NS because in NS you have NaCl, like the chloride, it is having, it makes the hyperchloremia. And then what happens over there is the high chloride, it gives efferent arteriolar constriction and it causes decreased blood flow, which has an increased risk of AKI. So to reduce that risk, so you need to give the balanced fluids. You can give an NS, but in a balanced way with more RL or plasmodies. So here in the giving RL in sepsis with septic shock also. So as the RL contains lactates in the liver, it converts into the bicarbonates and it helps in improving the acidosis of the patient. So here also RL can be like contraindicated in some cases where the patient is having liver failure. Is it clear, sir? Like,
Yeah, DV has asked the question. Is it solved for you, Mr. DV? And the second question is, what about the beta-lactam infusion? Swarna?
yes, definitely. As I told you, in the updated version of the sepsis guidelines, so we can give beta-lactam infusions like meropenem and piptas, like piperacillin tazobactam infusions. So it is advised to give the antibiotic infusions for over 3 hour period. So increase the pharmacokinetics and pharmacodynamics of the antibiotic. So which also like which gives increased renal clearance in sepsis.
So the question will be, so why, what is the benefit of giving by 3 hours?
It increases like it helps in the pharmacokinetics and dynamics for the
So to be
maintenance
the
to act on the
Chris,
bacteria.
so to be in a emphasized way, it will be like a, it is a time dependent killing the free drug concentration, which stays above the MIC for a higher percentage of treatment time.
Yes, sir.
So that is the thing. So
Yes, sir.
next is Kartika, how to measure optic disc elevation in elevated ICP.
We can measure the optic disc by using an indirect fundoscopy, or we can use OCTs also. That is mostly done by the ophthalmologist.
No, see, this ophthalmic, what you are saying, the measuring the ICP,
Optic disc
so that
elevation, sir.
can, yeah, so that can be done by the ED physician in the ER itself. So the by
Fundoscopy.
how you want to do, rather than
Fundoscopy.
fundoscopy,
We can optic nerve sheet diameter. We can assess using the our echo machine.
yeah, ultrasound machine by using the high frequency linear probe.
Sir.
So that we will call the measuring the optic nerve sheath diameter. Yes.
Okay, sir.
So, and what is the reason for increasing mortality in severe TBI with succinylcholine?
There's some studies have showed that succinylcholine can lead to an increased ICP. A mild increase in ICP can be there, and it is also linked to the in patient with if there's any concurrent hyperkalemia or muscular dystrophy, which can further increase the mortality risk.
Yeah. And how many days can you give 3% saline or mannitol? So the question is like
That
this.
that will be depend upon the patient clinical condition. We have to assess the response. We have to assess the continuous GCS, the repeat head CT, and depending upon the clinical condition, we can taper the dose.
So to be precise, it will be till the patients improve clinically or till the cerebral edema comes down. So we can give either 3% NS or mannitol. Yeah. And Swarna, you are there?
Sir. Yes, sir.
So just before closing it, just highlight the recent guidelines of the sepsis. So there are some 7 points which they have highlighted. So over the last one, coming first to the antimicrobial therapy.
Yes, so coming to the antimicrobial therapy, the recent guideline says that all these beta-lactam infusions can be or should be given over 3 hour period, either in sepsis or septic shock. So the
Okay,
other
that is
thing
one.
is
That is one point. And other thing is, so if you are
uh,
labeling it as a septic shock, so it should be given within 1 hour.
within
So if
1 hour,
you think the patient is having sepsis, so you can prolong up to 3 hours.
3 hours, sir. Yes, sir.
Yeah. And what is the hemodynamic management? And
So the target management of the BP is to maintain the map of 65 mmHg, sir,
yes.
with the IV fluids and with vasopressors or inotropes.
Okay. So MAP more than 65. And as when you're coming to the elderly, so more than 65 years or elderly, so we can keep the MAP around 60 to 63. So
Yes,
that's
sir.
what the new guideline says.
Yes,
And
sir.
anything you want to add?
No, sir.
thing is starting an A line, arterial line for if the patient is on uh, vasopressors with the maximum support or multiple vasopressors. So that will give you the correct mean arterial pressure, and it will be helpful for your multiple ABG samples. So that's
Okay.
what the new guideline says.
Okay, sir.
And regarding vasopressors, what is your thought?
Regarding vasopressors, the first line should be always the noradrenaline, sir. Even in then continues with the vasopressin.
Yeah. So thing is, what he says is, these vasopressors you can continue on the peripheral line. So if there are on the lower doses, so the
Yes,
patient
sir.
is receiving on the higher doses, so within 6 hours they are advisable for a C line.
Venous. Yes, sir.
Yeah. And the other thing is sepsis screening. So your thought on this?
So we have multiple SITS screening tools, sir. So initially the SITS criteria and QSOFA scoring was alone enough, but now the latest guidelines say that News and Muse scoring are more efficient than those guidelines. So patient is having more than five of new Muse scoring is better to get admitted in the hospital.
Okay, so he says is there is no role of SIRS in the prior one, and QSOF also is there. So he's telling to go on News or Muse.
Muse, sir. Yes, sir.
Yeah. The fifth one is the code sepsis systems.
Okay.
So as we have a code stroke, code blue, yes.
Yes, sir.
So the thing is they want to implement this code sepsis. So why? Because of the multidisciplinary response, which improves the outcome, and faster antibiotics, faster escalation, and more uh, benefit in the weaker systems. So what is he is highlighting is the faster antibiotics, the faster escalation
Yes,
fluids.
sir.
So that's what he mean to say.
Yes.
And sixth one is selective digestive decontaminations. So what do you mean by this?
So if the patient is coming with any peripheral infections like necrotizing fasciitis and all to do the dressings and any catheter related infections and all remove the source so that
Yes, yeah.
the further
So
deterioration might not happen.
he's telling to use in low resistance settings.
Yes, sir.
And the last key takeaways, what he says is antibiotics within 1 hour, which if
Yes,
the
sir.
patient is in shock. If you think the patient is borderline sepsis
Sepsis.
unclear, so you can go up to 3 hours.
Yes, sir.
And MAP, as usual, maintaining the target of 65. If
5,
it is in the elderly people, you can go up to 60,
60 to 63.
63. And screening news has taken over the QSOFA and use of the arterial line and
Yes,
implementing of the code systems.
yes, sir.
And other thing is, he is telling to give antifungals, and not on everybody, the two case by case cases.
Yes, sir.
So any cases you want to specify in this. So when you are not using in all patients, any specific cases you want to highlight.
Yes, sir. In patients with LRTIs and long-term ventilator-associated pneumonias and all, later developing sepsis and septic shock infections in later stages. So predominantly, we can give antifungals in these cases, and in some cases of like skin infections,
So
we
rather
can
than
give.
we put like this, patient who is immunocompromised, all the malignancy patients,
Yes, sir.
patients who are on prolonged hospitalization in the hospital for 1 month, 2 months,
Yes, sir.
patient who is on multiple antibiotics for prolonged days,
Yes, sir.
and a patient who is having an intra-abdominal infections or sepsis.
Yes, sir.
And the third one is use of albumin as a resuscitative uh, thing he is telling to consider, and is telling to avoid in traumatic brain injury.
Yes, sir.
Yeah. And the fluid also, so we can avoid in normal saline where you want to avoid.
In AKI patient or already having hyperchloremia or hypernatremia patients.
So you can use RL except in the TBI patients. So
Yes, sir.
yeah, that is the thing. Kartika, you want to add anything? You almost covered everything.
No, sir, that's
Swarna, you any thoughts of Kartika presentation head injury? Anything
No,
you have any queries?
no, sir. No, sir. No, sir.
Yeah. And lastly, is in the sepsis, they want to have a dedicated services and uh, patient care post critical illnesses services. So these are the things which he has implemented in the 2026 guidelines.
Yes, sir.
And that is a wonderful presentation by both of you.
Thank you, sir.
thank you, sir.
So we have almost done the presentation for nearly 2 hours. I think this is the first time where a webinar went for 2 hours. So I thank both speakers, Dr. Swarna from Somajiguda and Dr. Kartika from Malakpet, for coming and sharing your insights in the uh, sepsis and head injuries. As we, the emergency physicians, we are the frontline for all these, whatever cases it comes. So sepsis plays a major role. Simultaneously, head injury bears a major toll. So same patients can be coming with a PEA or asystole on the presentation, and the resuscitation should be started pre-hospital, and it should be continued in the ER and to be extended in the intensive care unit for a better outcome of these patients. So I thank both the speakers and Yashoda Hospital so for this wonderful insights of having a webinar every week. So in association with SEMI and Anbai. So every Tuesday, Yashoda Hospitals comes with a different topic of the latest thing by the expert panelists in the field of emergency medicine. So if there are no more questions, so we'll wind it off.
Thank you,
Good
sir, for
night.
moderating our session, sir.
Thank you
Thank
so
you.
much, sir.
Thank you. Bye.
Bye, sir.
Bye, sir.